Now I'll invite Dr. Shyamal Dwivedi, who is a brilliant, dynamic vitreoretinal surgeon, and he's going to talk about something that is becoming more and more prevalent, diabetic eye disease. As the longevity is increasing, as our lifestyles are getting worse, and particularly from where we come, Gujarat, it's the diabetic capital of the country. So we face this dilemma quite often. Significant cataract progressed rapidly due to diabetes, but the OCT shows macular edema, and he's going to share with us how we need to approach these patients scientifically.
Thank you for involving me in the IC. Thank you for the kind words shared. Good afternoon, one and all, and I am here to discuss how to deal with the diabetic macular edema along with the cataract. So as we all know, India is set to be a diabetic capital by 2020-30, and as we all are aware that it's a dreaded complication contributing to the burden of the society. And now, without going into much of the theory and statistics, we will directly come to the point, treating cataract and the diabetic macular edema. So there are two approaches or two ways to do it. The first approach is targeted to treat the macular edema first, dry out the macula, and later followed by cataract surgery 2-3 months later, once we are sure that the macula has remained dry for some time. And the other way is treating cataract and diabetic macular edema together with appropriate intravitreal injections or surgery, which is known as the combined approach, which we are currently interested in today's IC. So these are some indications of the combined approaches, but we don't want to go too much into all these details. Moreover, it is already proved that diabetic macular edema worsens if a diabetic patient is undergoing a cataract surgery, and thus managing that diabetic macular edema efficiently remains our primary goal. So this slide is again self-explanatory, but the main point to highlight is the need to join hands with a vitreoretinal colleague or for an appropriate diagnosis of diabetic retinopathy. We are again not going into the theory part of the diabetic macular edema because we are quite familiar with it. And as most of us know, these are the well-established diabetic macular management options. But the intravitreal injections are the most popular and widely used in today's era. So now let us come to the real world scenarios. So our eminent team member Dr. Aditya Sudhalkar was involved in the trials related to the dexamethasone implant, and they concluded that dexamethasone implant is a valid option in treatment of diabetic macular edema patients, those who have not undergone any treatment or those who are treatment naive. So here is our first case showcasing a cataract and a diabetic macular edema secondary to a non-proliferative diabetic retinopathy. So this patient was successfully had undergone phacoemulsification along with the dexamethasone implant, and even at the end of 3 months, the patient continued to maintain decent visual acuity and almost regressed diabetic macular edema even at the end of few months. This is a second case. This gentleman is a one-eyed patient and has an inoperable TRD in the right eye, and the left eye, the only seeing eye, has a diabetic macular edema along with the cataract. So this was a responsible task for us, and this surgical video of the same patient undergoing a phacoemulsification and IOL implantation. Once the IOL implantation is done, as Dr. Aditya Sudhalkar mentioned, that it is very important to keep the anterior chamber filled up with viscoelastic substance, and 3.5 millimeter from the limbus the measurement is taken, and the direction of the needle should be towards the center of the globe. So once it is in the center of the globe and the two planar entry is encouraged, once the implant is inside the globe, we are able to visualize the implant through the pupillary plane, and it is extremely important to see that implant through the pupillary plane so that we are satisfied where exactly the implant has gone. So once the things are finished, AC, BSS wash and site is massage, and that is marks the end of the procedure. So for the same patient, the post-operative result was very satisfying, and he had an excellent visual acuity of 6/6. Further, if you see, the patient also underwent a focal and a grid laser. You can very well see the regression of the hard exudates on the right side of the photograph. This is the previous pre-cataract surgery photograph, and if you see after the focal laser, there is a marked decrease in the hard exudates and thereby preventing future injections as well. This is a third case, and this patient was posted for a cataract surgery, and it looked like a normal fundus to everybody of us. However, the OCT had a different story to tell, showing both eyes having a diabetic macular edema. So he was subjected for a fundus fluorescent angiography to identify the reason for the macular edema. And so once the FFA was conducted, it documented a moderate type of non-proliferative diabetic macular edema, retinopathy, along with the macular edema, which was correlating with the OCT findings. Again, the patient was subjected for cataract and dexamethasone implant, which proved very fruitful for the patient, regaining a full visual acuity gain. This is a fourth case, and this patient with a diabetic macular edema was posted for a left eye cataract surgery, but this case was little different. And on fundus examination, it was clear that this patient has a proliferative diabetic changes. As you can see in the red-free image, that there is a neovascularization over here with a lot of capillary non-perfusion areas. We are more interested in the left eye of this patient. However, both the eyes had a proliferative diabetic retinopathy chain, but we were operating the left eye, so let us concentrate on that. This was a partially lasered diabetic retinopathy case, but this laser was not good enough to regress this NVE over here, and that is the reason we had to do something for this. So this was clearly not a case for a steroid implant, and this patient underwent an anti-VEGF injection along with the cataract surgery, and later we could see a total resolution of the NVE, and this is the area of capillary non-perfusion, which was further lasered with a PRP addition and some amount of focal laser as well. So this patient did very well in long run, maintaining a good visual acuity. So this is the fifth and my last case, and this case is very close to my heart. He is a young photographer and a young diabetic having all sorts of diabetic complications, and he presented with this picture showing a thickened posterior hyaloid, epiretinal membrane, diabetic retinopathy changes. These were proliferative diabetic retinopathy changes and some amount of subhyaloid hemorrhage in the left eye as well. So OCT showed a massive diabetic macular edema with a taut posterior hyaloid and an epiretinal membrane in both the eyes. The patient was subjected to different intravitreal injections before taking the patient for a cataract surgery. We wanted to make sure that the patient is free from diabetic macular edema. We tried different injections. The patient was given several injections, first dose, second dose, third dose, trial of mix and match of different anti-VEGF. But in spite of many injections, the right eye did not respond, but on the contrary worsened. However, the left eye behaved well after the treatment, and it was the responding eye. So this was clearly a surgical case, and now we went ahead with a combined procedure with phaco and a vitrectomy. So after a successful phaco implantation and in-the-bag IOL implantation, a 25-gauge pars plana vitrectomy ports were constructed. He is a young diabetic, so we expect that the vitreous to be very, very firm and very, very adherent to the surface. So in this patient, we used triamcinolone. So triamcinolone-assisted PVD was the aim, and in spite of trying many times, PVD induction was proving difficult, and at one point of time, I started losing patience. However, by continuous backup and encouragement by Dr. Shyamal and our senior Abhay Vasavda sir, I finally got hold of the PVD. As evident, the triamcinolone particles are coming up, and finally I achieved the PVD. And later on, after achieving the PVD, there was nothing more to do. Our aim was only to achieve a PVD, no ERM peeling, no ILM peeling, absolutely nothing. We just wanted to relieve the traction. We later on added pan-retinal photocoagulation to the retina before closing the case, and it was very, very satisfying to see a complete resolution of macular edema, and this eye never required any treatment for the right eye. We have 2 years follow-up of this patient without any treatment for the right eye. The left eye continued to respond very well to the intravitreal injections, and he is still on the left eye intravitreal injection. So our take-home message is it is very essential to identify the correct diabetic retinopathy stage and make the patient understand about their own condition, as diabetic retinopathy is a very complex disease. Now the time has come where we need to join hands with a retinal colleague for a better customized approach for the patient. And last but not the least, dexamethasone implant is an excellent choice for patient undergoing cataract surgery with diabetic macular edema in most of the treatment naive patients subject to proper evaluation. Thank you very much for your attention and engagement throughout this presentation.
Thank you, Dr. Shyamal, for sharing those wonderful case-based presentation. And I had one or two questions for you, Dr. Shyamal. Quite often, many of these patients have a significant enough cataract that we cannot, wait for 3 months, 6 months, etc., for the diabetic retinopathy to stabilize. And often, you and with your retinal colleagues suggest that first we want to make sure that this retinopathy stabilizes before you do any surgery. So, say for example, you decide to give an intravitreal injection and a cataract surgery is planned later. How much is the time duration, minimum time duration you would suggest? 1 week, 1 month?
So it again depends on what amount of macular edema or what type of retinopathy it is. But if you ask me, I would wait for 2 to 3 weeks before doing any cataract surgery or any other procedure onto the eye.
And when you're combining an injection along with cataract surgery, is there a preference of any one kind of injection over the other in terms of choosing either an anti-VEGF more over a steroid or vice versa, or it still depends on the type of retinopathy picture?
So basically, if it's a non-proliferative diabetic retinopathy and if we are combining with a cataract surgery, dexamethasone implant stands out. And if the things are different, because there is no much IOP rise, patient retina behaves very well with the dexamethasone implant, and it gives a sustained release for up to 3 months, taking care of the diabetic macular edema. But however, if it's a proliferative disease, I would reconsider and go ahead with an anti-VEGF. However, if we are not combining it with a cataract surgery, the scenario is altogether different. I would see the profile of the patient, how the retinopathy is, and probably my first choice would be an anti-VEGF injection.
And quite often we have patients who've undergone, 2 or 3 injections. We waited for cataract surgery. The VIA surgeon now you feel that now the disease is stabilized and now you can go ahead with cataract surgery. So if the macular edema is stabilized and the patient is undergoing cataract surgery with no actual macular edema at the point before cataract surgery, would you still recommend combining it with an injection in such eyes which have had repeated treatments already before?
So if there is no documented macular edema, I would refrain and just wait for the macular edema to appear once again. But if there is a slightest doubt, even slightest thickening, then I would go ahead with a dexamethasone implant or whatever is suitable for that patient at that point of time.
And pre-operatively, to us as cataract surgeons, would you recommend starting these patients more frequently or well before surgery on NSAID eye drops or something like that, or they don't help much in diabetic macular
So there
edema?
was a study I read a few days back, and they say that it doesn't really make a significant change even if you put on a non-steroidal anti-inflammatory drug. What helps is, like, diabetic patients tend to have a smaller non-dilating pupil or less dilating pupil, or pupil which would constrict immediately as soon as you enter the AC or something like that. So it would probably help a diabetic patient to sustain that pupillary dilatation. But I am not a fan of NSAIDs, and I usually don't give it to my patients.
Thank you so much.